Good afternoon, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Before we begin, 2 notes. First, a word of thanks to everybody who helped make today happen, in particular to Meredith Brown and Alicia Noel. Thank you. Second, I would like to note a new initiative from our school. At this time of COVID-19, it's more important than ever to understand the fundamentals of public health. That's why we have launched an online mini MPH with 6 hours of content on the core themes in our field, including health equity, the subject of today's event. I have just sent a link in the course via the Zoom chat feature for those wishing to explore it. Now, about today's topic. In the 20th century, US life expectancy rose from 47 to about 79 years. This would seem to suggest a steady advance of progress when it comes to health. But we know this is not so. Within overall improvements are inequities that manifest as health gaps. Race, place, and socioeconomic status are among the conditions that drive these gaps. Addressing these conditions is central to the work of public health and to the mission of our school. We are fortunate to have with us today a leader in this work. Antonia Villarruel is the Margaret Bond Simon Dean of Nursing at the University of Pennsylvania School of Nursing. She is a member of the National Academy of Medicine and holds numerous national leadership roles. She is a recipient of many awards and honors, including the Sigma Theta Tau International Nurse Researcher Hall of Fame Award. Her research focuses on interventions to reduce sexual risk behaviors among Latino and Mexican youth. One such program, Cuidate, has been disseminated nationally. On a personal note, Dr. Villarruel and I have known each other for a long time, and I have always enjoyed our conversations and learned from her. And I'm very much looking forward to learning from her today. Dr. Villarruel.
Hi, Sandro, and welcome everybody. It's good to be with you. I regret that I'm not there with you in person, but really happy to share with you some thoughts that I've had around health equity. I think as Sandro mentioned, I've been working in this area as a practitioner, as a researcher, and as someone who really looks to influence the policy area. So I'm not sure if you can see my slides or if I share the screen now.
You can share now, we don't see them yet.
Great. Is this right?
Yep, we got them now.
Great.
Yep.
I want to share some thoughts about health equity. And again, I've been a little schizophrenic as I've been putting this talk together. I think Sandro asked me, I can't remember when, it seems like a lifetime away, when I decided that I wanted to talk about advances in health equity. And then COVID came and I thought, well, gosh, the whole world is going to be focused on this pandemic. How are the issues of health equity going to seem relevant in this pandemic? But it didn't take long for that to evolve and to see for the scab to be ripped off this pandemic to really, I think, elevate the importance of these particular discussions. I have some exemplars around COVID, but again, these are long-standing issues and apply just about to any public health and health-related program that we might have. So when we talk about health equity, I think definitions are important. There have been a lot of conversations and work in this space, talking about equity, talking about social determinants of health. RWJ put out their whole issue around culture of health, social risk factors. But I want to provide us a framework and a structure to think about equity. And I would say the different layers or the different streams of equity, and again, areas for intervention in each of those as we're talking. So when we talk about health equity, or we talk about equality and equity, when we talk about equality, what we're doing is just looking at, when we talk about equal sums. When we talk about inequities, we're talking about differences in. And so again, what we know is that equality doesn't necessarily apply or guarantee equity. And so again, those distinctions are important. So when we talk about health and we talk about health disparities, we're talking about differences that are associated with economic, social, or environmental disadvantage. So again, we know that smokers have a higher risk of lung cancer than non-smokers. That's a disparity. When we talk about the issues of health and equity, those are really based on ethical judgments about those differences. Is it fair that smokers have higher rates of lung cancer than people who don't smoke? We know that migrant farm workers, for example, have a lower life expectancy because of labor, because of exposure, because of pesticide exposure. Is that acceptable or not? And so again, the health inequities are based on ethical judgments about these differences. When we talk then about health equity, it is the belief that everyone has the right opportunity to attain their highest level of health. And the COVID example here is, again, does everybody have access to COVID testing? The question should be, should everybody have equal access? And again, whether we count that as a disparity or an equity is, again, our beliefs about who has the right and who should have access to that. So when we're talking about health equity, they're based on a number of key elements. As I mentioned before, it's reflected in the issue of social justice or fairness related to equitable resources in the broadest sense. Health equity is based on a human rights perspective, including not only the right to health, but the right to participate fully in society. Health equity includes equitable access, not only to health care, but also to the social determinants of health, again, to clean water, to food access, to transportation. We know and understand that the equitable access is shaped by political structures that are key determinants of health, and that ultimately it's a political process. We also know that advancing health equity requires more than just health care, and it requires us interacting with other sectors. So I found this, this graphic pretty, which I modified a bit, helpful to me in thinking about the different perhaps layers, levels, pathways in achieving health equity. We have the downstream factors, which relate to what happens perhaps in a clinical care setting, to more midstream factors, which can happen in the clinical care setting at the point of care, but encompass more than a physical diagnosis. And then finally moving to the community impact and where we need to go. And again, I think there are different strategies and different contexts for each of these that I want to talk about moving up, and points of intervention moving forward. And I want to talk about each of these then as we go separate. So when we're talking about individual type of interventions or individual conditions and how that affects health equity, I think of practitioners at the point of care. And certainly there's been a lot written in the literature about the impact of implicit bias and in interactions, the need for cultural competence in interactions to prevent disparities. And the IOM, as you know, put out a very important report called Unequal Treatment that outlined, again, the impact of bias on clinical care. So when we talk about implicit bias, we're talking about a stereotype that's really not in our consciousness, maybe not in our awareness or control, but again, does affect how we treat folk, our preferences, our assumptions about what brings people into care. And again, when we're thinking about the coronavirus, I think I would say either sometimes hard to think that these are implicit when they are so categorically out there. But again, our belief about immigrant populations as a whole, and here their relationship to, to COVID-19 really has influenced our interactions with people. So the idea that people would not go into a Chinese restaurant because they were afraid of getting the virus, again, implicit bias, explicit bias, but again, brought out by fears or again, popular conceptions. And again, those affect us and our interactions at the point of care. So a way to combat that, and again, this is in the early areas, and we're starting to think about how is it that we interact with people who are different than us. The notion of cultural competency is one that infiltrated health professions education. and that is looking at the attitudes, knowledge, and skills necessary for providing quality care to diverse populations. Again, a large body of research that tells us that the consequences of implicit bias are decreased in unequal access to care and increased health disparities. I think some recent examples is that still documented mistreatment of women during pregnancy based on ethnicity, who reported disproportionate amounts of poor treatment, including verbal abuse and physical abuse at the time of delivery. And then again, a large body of research that says higher levels of implicit bias yields lower levels of patient adherence, follow-up appointments, trust in healthcare providers, and overall adverse effects on assessment and care. What I wanted to say here, I'll go back in terms of interventions. I'm ahead of myself here. The next point that I want to talk about is, again, social determinants of health at the point of care. And again, it's still talking about the point of care and figuring out what is it that we can do as providers in mitigating some of the impact of these of risk factors or environmental factors that might affect both the prevention and the treatment of different conditions. So, first of all, a definition of social determinants of health, which I'm sure most of you as public health professors know, is that it's conditions in which people are born, grow, live, work, and age. And these are shaped by the distribution of power, money, and resources at all levels. And so everyone is affected by social determinants of health. It's not something that affects just one population or the other. And again, certainly something that we need to consider as we are at the point of care. So there's been a great body of work that's been done both in this country and abroad in terms of what are these social needs and how should we think about these at the point of care. And I will tell you that my emphasis on the point of care comes from my role as a nurse. And I think discussions with other colleagues who work perhaps at the policy level in structural related areas. So for example, one of my colleagues, excuse me, one of my colleagues, David Williams, who I love and respect, we were working on a project together, excuse me, looking at the issue of maternal care disparities in maternal outcomes, specifically related to African Americans. And David brings out this very compelling evidence that says, taking a look at the root causes, and very compelling evidence that says, if we really want to address these disparities in maternal outcomes among African Americans, then we really have to address the issue of residential and racial segregation. And I remember when he was talking about this and providing that compelling need, it's like, I get it, I understand it, I believe it, but that's not going to happen in my lifetime. And if I have a pregnant woman that I'm dealing with that I know is at risk because of where she lives and because of these other factors, what am I supposed to do? So, I mean, our intersection at the point of care is not the cure-all, but it is an opportunity to intervene. And here are two ways in which us as healthcare providers and in the healthcare system can and do intervene. One is in social needs, looking at informed care. And these are activities that involve modifications to traditional healthcare that account for person's social context. So again, taking a look at transportation, the use of translators during a patient visit, assessing data on perhaps food access, and again, medication access. But there are other interventions that, again, are getting more attention, and that's social needs and targeted care. And these are activities in clinical settings that seek to address patient social needs directly, such as the income assistance, housing, and food supports. And there's a growing, I say growing appetite, but a growing awareness that there is, again, an opportunity to intervene at the point of care. our Secretary of Health, Secretary Azar, again, a very forceful statement that says it may surprise you, which it did, that we are thinking about healthcare and social services very specifically in the context of social determinants of health. So they're very tangible. It's a very tangible and frightening challenge. This can feel like a frustrating, almost fruitless position for a healthcare provider who understands what is driving the health conditions they're trying to treat, who wants to help, but simply can't write a prescription for healthy meals, a new home, or clean air. So the question for us is, what is the role of the healthcare system in providing this? Certainly the attention to value-based care is one that is driving some of the intervention around social needs. But again, I'm not sure we've really delineated the important component of what that is. Certainly, as we're talking about COVID-19 and social needs at the point of care, whether it's in the diagnosis, treatment, or in recovery, issues that we have to care about are social distancing and the ability to social distance, given, again, where people live, whether that be on the streets, in shelters, in crowded apartment buildings, the issues around food insecurity, which again, because of the unemployment area, are just absolutely skyrocketing. Housing, I mentioned, and then the economic impact of staying at home. And here, very graphically, again, this is at the beginning of the epidemic, points to, again, an income inequality and how the effect that has had on flattening the curve in many of our major cities. So again, the blue curve represents those that are at the higher 10%, and again, how quickly that's impacted, and again, slower areas for those who are in the lower 10% in relation to poverty. So again, a graphic example in this current context. So we do have many examples, and of course I go to my profession in nursing, as to how we have been successful in addressing social needs and at the point of care. And these are a number of successful programs, many of them research-based, who have evidence of successful patient care outcomes, as well as economic data that says that these, in fact, are feasible. So a few, for example, that have emanated from Penn have been around caring for elders. The PACE programs, I think, are a great example. Those programs for dual eligible Medicare, Medicaid patients, the ability to care for these vulnerable populations outside of nursing homes with the proper support. The 11th Street Family Health Services, an example of an FQHC lookalike that provides comprehensive services both for social needs and again for addressing those in healthcare. The Centering Healthcare Institute, which again is around pregnancy. So again, a number of different models that we have that say we can effectively at the point of care address these social needs. I was involved in a study that took a look at these exemplars to figure out why is it that they're successful both in economic areas and in patient care outcomes. And we outlined these, put these together in relation to the RWJ framework around a culture of health to see if in fact these models did address aspects of the culture of health, and to see whether or not those were part of what their success stories were. So again, what you can see is in most of these models here, the areas of the culture of health that these models were successful in addressing were the integration of healthcare services and systems, looking at cross-center collaboration to improve health and well-being, creating healthier, more equitable communities. So again, the care that they were giving, although it might have been within a particular building, the services and the integration of these clinics or services within the greater community was something that was common. And again, strong collaboration with community stakeholders. So again, this demonstrates that there are elements in these successful models that were also congruent with the culture of health. One of the issues and I would say not just in accelerating some of these nursing innovations, but other innovations as well, is that there needs to be, again, an infrastructure, a more stronger payment method that leverages the contributions of nurses for us to be able to work in these emerging roles. We have evidence that these models are effective, but where we get caught up is in the scale up. And so again, we need structural changes, policy changes to in order more stable funding in these particular areas. One of the policy changes that I'm a big proponent of is that we need to remove barriers that discourage nurses from practicing to their full scope. What we have seen in this time of COVID is a number of these restrictions being loosened up in order to address the health needs of the population. So one example where that has been loosened up, where nurses have done very well in, has been in the area of telehealth. CMS released new regulations that says they will in fact reimburse nurse practitioners and other providers for reimbursement for providing primary care and also chronic illness management. So that's the type of policy change that needs to happen across the board and hopefully will remain post-COVID to allow these type of innovations to move forward. Other opportunities, again, is looking at creating organizational structures and incentives that allow for, again, health systems and other areas to address social needs at the point of care. And again, I'm a big proponent of making sure that nurses are at the C-suite level to enable some of these changes to happen. So the key questions as we're looking though at addressing social needs in this context, as I mentioned, is what is the role of health systems in addressing social needs at the point of care? What are successful interventions that can and should be implemented? How is it that we should be taking a look? What is the healthcare system's role in addressing structural issues? And what is the role of anchor institutions in achieving health equity? I think you'll find many healthcare systems, mine included, who are situated in areas of great poverty. And so the role of what is our role in ensuring not only that we have delivered great healthcare, but what is our responsibility to advancing health in the neighborhood in which we live in? And that moves to not only access to care, but how it is we employ the residents in West Philly, as an example. How is it that they're included in decision making around environmental changes that move forward? I think we do a good job, but I think we have long ways to go if you take a look at some of the incidences of illness within our neighborhood. Then I think we need to take a look at what does the evidence tell us about interventions at the point of care and addressing social needs. And I will say that there's mixed evidence. I think with innovations we have to keep trying, but I think many of us were perhaps surprised and disappointed by the report from the Camden Coalition around healthcare hotspotting. Again, made valiant efforts to address very both ill and persons with very complex social needs in the emergency room by providing a whole array of services for them. And what they found was that despite the services that were provided, there was a regression to the mean with the control group, so that in fact, over time, the interventions and support weren't as effective. And so that begs to question, do we need more targeted approaches? Are there earlier interventions that need to be in place? Are the targets of the interventions the right ones? Is there a more higher need for intervention for non-related healthcare services, such as those for increased housing? And then do practitioners have the skills and the teams necessary to meet complex demands? Another model that, that of course I'm very familiar with because it originated at Penn is the transitional care model, in which advanced practice nurses work with a specific group of patients who have dual diagnosis, complex health needs. And again, it's a nurse practitioner working to address these needs in the transition from home to health. That has been a very successful model. And I think the questions that come into place is it too specific of a model? Does it have applicability to a wider population? And again, I think you'll see aspects of the transitional care model. It's very well evidenced, research-based, and that has shown some good output. So again, thinking about what are the key elements of this model that can be used and applied. I think the success and the not success of both of these models tell us that we need, that not one size is going to fit all, that we need a variety of interventions working at different levels of care for different population in order to assure good health outcomes for all. But I think both provide us with good evidence base related to outcomes that, again, I think we're going to need to continue to implement and continue to monitor as well. So finally, at the top of the ladder here is addressing structural racism. And so that is as a definition, a system in which public policies, institutional practices, cultural representations, and other norms work in various and other reinforcing ways to perpetuate racial group inequity. It does go beyond race, and I will tell you we have plenty of examples in our, I would say not even in our history, but in our present that can be traced back to historical decisions. This one I'm not going to say I love, but I think we have to acknowledge racism is as American as baseball. And what that says to me is that it's very well integrated into past and current processes. Perhaps the names and faces have changed, but I think, look, you know, certainly we take a look at the legacy of slavery and white supremacy and what that is and how that is playing out in current politics. We take a look at, you know, the Native American population, issues during World War II around Japanese immigrants, and again, the internment of them during World War II. The early laws that we had that were very anti-immigrants, first against Chinese and then later to, you name the population. Issues around Latinos and a specific population, migrant workers who again have no power, no controls, but yet are the backbone, and certainly assaults on women as well. So we are naive to think that what happens in larger society doesn't affect us in the delivery and how we're thinking about healthcare. So we can clearly point to the racial segregation, how its impact on hospital closures, physician flight, and the effects of environment and stressors. We know that there have been a cultural and legislative impact on women's health, access to care, and leadership roles. And again, discrimination and disparities in HIV health policy and psychiatric disorders related to the link for LGBTQ protections that go to insurance exclusions for transgender patients, and then on and on. So we have plenty of examples here. And when we think about structural racism in health, we can and should be thinking about the economic injustice and social deprivation, such as residential segregation and what that means to providing resources for those communities. We look at and think about environmental and occupational health inequities, the exposures to toxic waste, decisions that were made, for example, in the whole Flint contamination, and looking at the disparities that had for an entire population and for an entire generation. We look at the targeted and marketing of harmful substances to minority communities, and the discriminatory incarceration. I could go on and on and on about the issues of incarceration and the impact on individual health and community health and family health. The political exclusion, what's happening in relation to voter rights and voter suppression that are evident even as we're looking at this election, and looking at state level structural racism as it relates to healthcare outcomes. So, you know, again, some of the political participation, employment and job status, educational attainment has been associated with higher rates of heart attacks in African Americans, but has actually been protective for white populations. And again, looking at the issues of low birth weight in both Latino and African American women as compared to white populations. So there are, you know, what I want to focus on a little bit is, so where are the opportunities for intervention? Again, there have been a couple initiatives, both at the national level and state level, to address some of these that I think really incorporate some of the downstream effects that we talked about in terms of cultural competency, some of the mid-level, and then also the structural component. So there's been movement by a number of African-American congresswomen who have put together a number of bills called the Black Maternal Health Momnibus effort. And again, it's legislation that has been in disparate part, and what they're trying to do is to put these and block these as a whole to address effects from a wide range. So looking at making critical investments in social determinants of health and maternal outcomes, looking at diversifying the workforce, which again gets at the point of care and clinical care, looking at improved maternal health care and support for incarcerated women. I was shocked, angered, couldn't believe that incarcerated women in many states, when they go to deliver, have to deliver in shackles. I mean, is that any way to welcome new life here? Taking a look at investments in maternal mental health care and incentivizing high quality maternity postpartum care and coverage, which we know has been lacking. In the state of Michigan, to address some of these disparities, the legislation is looking at expanding healthcare coverage, looking at implicit bias training. So providers are going to have to engage in that as part of their licensure. They're looking at expanding evidence-based home visiting programs, such as the Nurse-Family Partnership, which has been an effective intervention at the point of care, but at homes, that has had demonstrated good long-term outcomes for moms and for babies. And an important healthcare component, expanding access to family planning and contraceptive services. You know, so again, and what I want to provide is, again, additional examples of, you know, this is not an either or, but we have to look comprehensively at how we address different health-related issues or health-promoting behaviors by a variety of areas. I think that's the role, not just of nurses, but of all healthcare professionals, of public health professionals as we move forward. So some examples are, again, how is it that we look at promoting breastfeeding? Although we know, everybody knows the benefits of breastfeeding, and we know that there's a low uptake of breastfeeding, in particular among low income and minority communities. There is a clinical solution, which one of my colleagues has had great success both here in the United States and internationally, is to, again, look at models of care during delivery and postpartum to ensure that there is good support in promoting breastfeeding and for moms as well. At the healthcare system level solution, it's implementing informed decision-making across hospitals, and again, making sure that interventions like the Nurse-Family Partnership are available at the community and among vulnerable populations. A policy solution, an upstream solution that's needed is to be advocating for policies to improve lactation support, both in the workplace and the community. So one of the things that I've been really happy to see, both within my institution and in airports and in other areas, have been these areas that promote, that are available to breastfeeding women to have access to wherever they are. The issue of firearm violence is again an issue that we deal with, certainly in Philadelphia, in Michigan, where I was from. I am sure in Boston, although I'm not aware of what their statistics are. But we know that there's a disproportionate burden of interpersonal gun violence. And again, if you take a look at this map here, these are redlining districts that were promoted as far back as the 1930s. And so again, these were geographic areas where loans for housing were not allowed for certain populations. And what you can see is that these redlining districts have contributed to lack of resource investment in communities, and that in turn has contributed to high levels of gun violence. So when we take a look at the clinical solution, again, it's how is it that we institute, primary and secondary prevention strategies at the individual, community, and environmental level. Again, thinking about how is it that we discharge someone who's had a gunshot wound back to the same community where they were shot, and how do we support them and others in that particular family. When we take a look at the healthcare system solution, how is it that we invest in neighborhoods to address the upstream determinants of health? And again, great work, Sandra, I think probably at Columbia, where you were as well, that investment in green spaces in communities have been shown to decrease the amount of gun violence. So how is it that, again, as healthcare systems, should we invest in promoting some of that area? And then policy solutions. Again, the need to recast fire violence as a public health crisis, which means that we should be able to monitor effects of gun violence. The development of a national violent reporting system embedded in the CDC is one initiative that's taking light. And then investing long-term in these enterprise zones, or again, neighborhoods where we know that violence is an issue, and figuring out at the community level what can be done and what sort of resource allocation needs to be made. Cardiovascular health is another important health disparity, and I wanted to share some efforts by my interdisciplinary colleagues at the School of Nursing, social work, social policy and practice, and education. And this initiative was supported by this young man here, Calvin Bland, who was at the Robert Wood Johnson Foundation for a period of time, who was very invested in Black men's health. And so he supported fellowships for fellows from these three schools to come together to address an area around Black men's health. And so the area that I'm framing that they addressed is cardiovascular, or framing it in a health perspective, is cardiovascular health. And we know that Black men experience a disproportionate burden of hypertension-related mortality and death rates. And we also know that Black men have higher rates of incarceration, and that the experience of incarceration has adverse effects on cardiovascular health. So the clinical solution would be, there's a variety of health interventions, medication, lifestyle changes that can happen using an interdisciplinary approach. But what we're looking at is taking a look at keeping men out of jail, out of the incarceration system. And we're doing that by looking at a diversion program in which first-time offenders for nonviolent crimes have a choice of either entering this diversion program or else going to jail. The diversion program addresses both vocational, education, housing, and other supports to address, again, the root causes of perhaps what their infarction might have been, but also as a way to help them to invest in their health. So we're very excited about the program. I think we just started recruiting and then COVID happened. So we'll see where we go. Again, the policy solution is let's take a look at at criminal justice reform, what are alternatives to jail, and again, the program that we're looking at. And again, luckily, we have the support of a DA who is interested in supporting policy solutions and diversion programs. Another program that I'm not going to spend a whole lot of time on is another program called Thrive that was developed, again, to help in the transition of elders from the hospital to home. So these are, again, elders who have had multiple chronic conditions. The program looks to identify folk early in the hospital, to introduce and require home visitation by an advanced practice nurse who will then work on coaching them for maintaining their health regime that they started in the hospital and working in the transition to home. So again, this is an example of sort of the social determinants at the point of care. And as I mentioned before, with other components of similar programs, what's really needed is, again, reform in policy and in payment. I think many of you are familiar with the health impact pyramid that was developed by Frieden, which I think has still very important relevance to me. I added the component of policy because I think that's where we need to act. And more, I'm thinking we have to start addressing the policy level first, and then that's going to drive our ability to address and have even a greater impact. The same has to do with, as we take a look at the issues of implicit bias and structural racism. You might think that it's the implicit bias that develops policies that are responsible for structural racism, but I think there are others that will argue that it's the other way around, that it's the structural racism and the deliberate policies that we have that in fact support and feed our bias at the point of care. So, in conclusion, looking at how we need to combat the systemic issues that yield disparity, we have to recognize that structural racism is nothing new, but we have a strong imperative. And I would say we have a stronger imperative now to push back. That as we're seeing in this COVID epidemic, that health equity can't focus on clinical care. As we're looking at the distributions of funds for even small businesses, the inequity that's happening, the LA Lakers don't need a bailout, but perhaps a mom and pop store, a bodega, might do, but those folk aren't accessing the monies that were meant to sustain some of that work. We need to take a look at legal structures and policy that are the foundation of oppression, and that change begins with structural policy-driven solutions, as I mentioned. And that achieving health equity means a cultural shift in priorities, dedicating for justice on all fronts. I love this quote by Ibram Kendi, who says, "People implement racist policies to protect their own political, cultural, and economic interests, and then perhaps on the principle that the best defense is a good offense, deploy racist ideas to advance those policies." So again, for me, that just illustrates that the need for us to move is in that policy direction. So questions I have for you all, and again, hopefully it's hard to engage in a discussion here, but maybe I can with Sandro, is how can health professionals, health systems effectively address implicit bias, the social determinants of health, and structural racism? When do we lead? How do we support and collaborate? What types of partnerships hold the most promise for addressing health equity and structural racism? I put two of my favorites, the educational system and the criminal justice system. How can we scale and spread effective, my bias, nurse design, nurse-led innovations and strategies for addressing social determinants of health and advancing health equity? My priority is full scope of practice at the federal, state, and institutional level. let me end here with a picture and a quote that comes from the National Academy of Medicine Culture of Health Initiative, which I'm privileged to be a part of. And as part of the initiative, and I'm really out of the box thinking for the National Academy of Medicine, designed a call for art in the loosest forms to ask people how did they it was called Visualizing Health Equity. What did health equity mean and how did that move forward? And this is a painting from Connie Kambike-Heller, who says, when we begin to ask each other what we need for our families and our communities to thrive and take seriously people's diverse needs and desires, we will begin to hear, see, and experience health equity. These are the signs of health that she has portrayed. These are the signs of equity. These are the signs that well-being of every human being and every community lies at the heart of every law, every policy, and every decision about shared resources that we as a caring society would make together. So that resonated with me. I hope it resonates with you. And I will look forward, Sandro, to discussion. I don't know if you can hear, but they're cutting my grass outside.
There are these complexities that we all have in working from home. Tony, that was wonderful. Thank you. So we actually have a number of questions, and I'll encourage the audience to submit questions through the Q&A feature. But if I may take the chair's prerogative before and ask you one of my questions, and then I'll move on to the other questions. So, I often look at these talks through the lens of our students. So when a student hears this, we have our students care very passionately about these issues, as they should. And I'm actually really proud that we've built a school where we attract students who care about these issues. If you had one piece of advice to students, particularly at this moment in time when, as I've said many times in the school, this is the time for public health. For a student who cares about these issues and would like to make sure that they contribute to building a healthier world and one where there are fewer health inequities, what's one piece of advice you would have for them?
Actually, I think I have a couple pieces of advice. And I think, one is to find out where your passion lies. There are so many opportunities that are available right now. And our students, I think like your students, are chomping at the bit. This is their call to action and they want to make a difference and want to make an impact. And there are so many opportunities, whether it's from food distribution, to doing testing and counseling, to doing contact tracing. I mean, there absolutely is a need for the work that you're being prepared to do. And we can't wait for you to graduate. We can't wait for you to do that. So that's at the, this is what my heart sings and what feels good. But I will tell you, and I think I said this in an interview, there are two things that you all need to do. You need to vote. You need to vote, and you need to encourage others to vote. Your candidate may not be the perfect candidate, but you can't sit back and say, well, I didn't get what I wanted, so I'm just going to sit back because it's not going to make a difference. It makes a huge difference. So I'm pleading with you, go out and vote, be active, vote with the candidate that you think is going to make the changes that are going to advance health equity. The second thing that I said in there, and again, it surprises me at my age how still naive I am around the census. And that is for you to be counted and for you to make sure that others in your community are counted as well. The distribution of resources is based on the census count. And if people aren't counted, they're absolutely invisible. Resources aren't coming to those communities. So I'm sure in Boston, like in Philly, there's many initiatives that you can get involved in at this point, but it's also a personal point that you can make sure that you do for your families and for those that are around you. And college students need to count. So be counted and vote.
Thank you. Okay, so now let me go to questions from the audience. I'll start with a question from Carla. How can social work and public health advocate for these issues, particularly in the context of COVID?
Again, I think there's, we were just talking about this today. I think taking a look at the political structures and again, what's happening at your localities and state, But there are a number of policy issues that are moving forward now, specifically in the area of the federal legislation around the CARES Act. There is going to be another wave. And so what are the kinds of things that we should be taking a look at and advocating for? So again, having conversations, getting your impact, your input as public health, social work professionals, talking to your legislators, talking to legislative aides about what's going on and moving that particular thing forward. I think there's certainly opportunities at the city level, within your district, to again advocate for those policy changes and for resources to get into those communities that are needed right now. So I would say, as everyone is still trying to look and to figure out what's going on, it's an opportunity for you to provide leadership and direction and help amplify the voices of the communities that you're looking to serve.
Let me ask a related question from Kay. The question is, how do we get public health researchers advocating for these issues, particularly moving beyond political debates and improving the general public's understanding? And what's the role of getting researchers into politics as part of that? So a couple of questions there in one.
Yeah, I think getting researchers, and Sandra, maybe you can help me out with this one, because I want to make sure I understand the first part. But I think getting research into politics, I think there's different levels or different things to think about. I always say, I'm not sure I want a researcher in every political area. What I think our role as researchers is providing the best evidence that we can to inform policy decisions. That's what our role is. And if we as researchers aren't clear about what the policy impact of what we're doing is, we better be clear. We better be clear. I also think that it's important that we hook up with those that are better in the policy making space. I mean, there's a lot of advocacy organizations who need the work that we're doing as ways to help make the argument and help propose solutions that are evidence-based to be able to move that forward. So that's what I think the role of researchers are. And Sandra, I'm not sure I understood the first part of the question.
Well, I think the first part is, and then I'll jump in with some thoughts on this as well, is how do we get research to change what the public understands and what the public thinks?
That's a hard one. I think first of all, recognizing that research doesn't always lead to good policy. I think in this day and age, not everyone believes the science. I mean, you hear and you see. I mean, look at the vice president yesterday. I mean, seriously. So you have something like that. It destroys whatever evidence that you have about what the public health experts have been saying. So it's partnering, I think, with people about how to get the message of the best science out there and forward. It's educating, and again, being good role models as to what you want and need to have happen here. So looking forward to your thoughts.
No, I agree with that. I mean, I'll add a couple of things. It's I do think that a core job of academic institutions is to generate ideas. I actually think that's really our core job, is to generate ideas and then to transmit them to the next generation. But part of that is figuring out ways to translate those ideas to the public. I mean, part of our job is to create ideas and not to let them just be there. Now, I'm a big believer in the academic enterprise. I think the job is to generate ideas, but I also think that we should engage in translating those ideas through any means at our disposal. And I must admit, I see a really promising generational shift on this. That I actually see faculty who are at the earlier stage in their career are much more adept than faculty sort of my generation at doing this, at actually being comfortable generating top-notch scholarship, but also engaging in the public conversation. And I think that's terrific. I actually think that universities and schools should encourage that and create vehicles for it. But I do think it's important that scientists are part of the public conversation while being very careful not to compromise the science and the integrity of the science. About the researchers and politics, I agree with you. I tend to think that there's a very specific role for scholars and researchers. By way of metaphor, the way I often think about it is scholars and researchers are players on the field of any of your favorite games. Politicians are the referees, and I think one has to choose what your role is. I think we need a referee and we need players on the field, and I think I would much rather be a player than be a referee myself. And, but obviously you want referees, and one of the failures at the current moment has been that our referees have not acted with the kind of integrity and with clarity of thought that we would like them to have acted. But I think sometimes we diminish our role as researchers, and hopefully the metaphor helps us see that ultimately there is nothing's happening without the players on the field. And we, by generating ideas and translating those to the public and teaching the next generation of students, that is our contribution. Let me ask a next question. This one from Catherine. How do we prioritize policies to address inequalities? Policies that advance one group may not advance another. How do we pick which ones to implement first? It's a hard question.
Yeah, it's a very hard question. I'm not sure that I'm going to buy the either or. I think there are certain policy areas that might look to pit one group against the other, but I think if we're thinking about, for example, clean water and air access, I mean, that's something that benefits everyone. If we're taking a look at if we're looking at, I go back to incarceration, for example. I mean, we know that disproportionately affects Black and Brown communities. We know there's evidence out there that says, early release, some of the programs don't disproportionately affect communities or have an adverse effect on communities if they're, early release, or that jailing didn't do anything to prevent people from, didn't actually reduce crime. So the narrative that many people use, and especially in this time, is that if I get this, it means that somebody else isn't. I mean, I hate that the example of it's making the pie bigger, but I'm not going to buy the false narrative that every policy that we have is going to pit one group against the other, the have and have nots. I think it's really taking a look at what are the basic rights that we as Americans, we as human beings should have, and making sure that that's available for all. I mean, the system that we have right now is not equitable. I mean, it's not equitable. And so I think to think that what we're doing is going to benefit one versus the other, it's not going to be equal. It won't be equal, but it will be equitable. So that's the narrative that I would really try to avoid. And I do think sometimes that, this identity politics does get in the way of bringing about more broad changes that will affect and can affect most populations. So,
thank you. I think it's a really good answer. Separate, totally different question from Tina. Can you comment on climate change policy and how that contributes to health equity?
Well, I think that's another example of a change or a policy change that has ramifications for everyone. So I mean, that is a policy that's not going to benefit or disadvantage one population versus the rest. That's one that has total, that has I would say a good impact on everyone, and might inconvenience folk based on prices of fuels or et cetera. But again, I think figuring out what the goal is first and then developing the policies after. I think climate change is a good one. That's, sort of universal policies that we need to make sure that people understand how in fact that does benefit everyone.
Separate question. There's a few questions around the healthcare system. I'm going to try to condense them a little bit. So the questions I think is characterized by Anne, who says she is a nurse who feels ashamed to be a health professional in a country where we stand out as the only industrialized nation that allows a strongly profit-driven healthcare system that leaves many without needed care, destined to live sicker lives and to die prematurely. And which, by the way, I agree with completely, that characterization of our healthcare system. So then tying it into, Miriam also had a question about, what are our biggest barriers to creating a more equitable health system? And what are solutions? To what extent does Medicare for all fit in? You know, if I were to distill these questions, I think it's, we recognize we have an inequitable healthcare system. Those of us who think about this carefully are embarrassed to be part of a country which has such an inequitable healthcare system. How do we, you know, why, what's in our way, and how do we move forward? How do we solve this?
Well, I'd love your thoughts on this as well, but I think there's a couple. I think the most salient one is payment and how healthcare is paid for. And who has access to insurance or not insurance. You know, I believe insurance isn't the answer to all, but the system of who has access to care and who gets paid and what it gets paid for drives a lot of inequities. You have so many players who are making profits within the system. It's not just the institutions, but all of the related businesses. You think about pharmaceuticals, for example. You think about those that are in the durable medical equipment areas. You think about senior care and senior services. And I mean, don't even get me started about what happens in nursing homes, but that's a direct result of how care is paid for. So these solutions aren't going to be easy at all. And I'm not sure I believe in Medicare for all, but I do believe that, you know, health is a basic human right, and there may be, we have to think about different ways to be able to get there. I think about, again, payment reform. I think the idea of value-based payment has moved the healthcare system more towards addressing social care needs, because it does, you know, it's not just a blank check to the healthcare system who can write, who can do whatever procedure they want and expect reimbursement for. And so the notion of value-based payment, I think, is one component that is moving us in the right direction. But I think it's going to take a lot of incremental, you know, levers on all sides moving that forward. And then I think the you know, maybe the final thing is that, you know, we also have to change. We believe that, you know, hey, if I want a particular treatment, I should be entitled to that particular treatment. It doesn't matter how much it costs. But if I want X surgery or X, you know, proton therapy, I should be able to get it. And my insurance should be able to pay for it because I'm an American and I have that choice. But, you know, it's not so much as the death panels that people were talking about earlier before, but there are choices that can and should be made. We're very consumer driven, and somebody needs to be able to tell us, no, you can't have it because it's not evidence-based. It's not going to get you the outcome that you have. And if I have to make a choice between, as a society, between this person and this person, you know, you may end up on the short end of the stick sometime. So those are all huge changes that, you know, I'm not sure I see happening in my lifetime, but I think these, you know, again, attacking it from all ends is where we're going to need to go. But Sandra, I'd be interested in what you think about.
Yeah, no, I mean, I actually agree with everything you said, Tony. I think I think payment is really critical. I think payment's really critical here. The other aspect which I would add, which I didn't hear in your answer, was the need for a shift in emphasis on primary care from tertiary quaternary care. And the truth of the matter is that the American health system, such as it is not really a system, of course, a patchwork of various pieces, rewards tertiary quaternary care, and as a result, the larger proportion of medical students go on to become specialists. And there is nobody in the systems whose job it is and who has the authority and responsibility to manage a whole person care. So although we talk a lot about the whole person and the whole person's well-being, it's actually nobody's job in the health system to do that. And you're seeing more and more systems, like, for example, like Kaiser, that are closed systems, that they are making those investments in creating more primary care providers because they recognize that without that, you're never going to achieve better health. And of course, they have a financial bottom line that for something like Kaiser, it benefits them to have lower costs by having healthier patients. So I do think that primary care has to be a core part of it. I think primary care is a broad term. I mean family physicians, I mean pediatricians, I mean nurses, I mean social workers, essentially the cadre of health professionals whose job it is to look after the well-being of the whole person, and who then helps the person manage their the rest of their health needs. And I think without that, we're not going to get to equity within the health, to a health system that achieves equity.
Right, and I would say that that's a payment issue.
Yes, I think a large part.
Pay, again, it's a chicken egg thing. If we valued primary care, we'd pay for it more, or we'd incentivize people in order to be able to do that. But it's not, so therefore it gets the short end of the stick, and we would rather pay for the higher priced, higher skilled person to do that. There are people who would love to take on the primary care role, and I will tell you that's nurse practitioners for sure. But we're prohibited in many areas and many states from being able to do that. So,
let me go to a different question altogether from Griffin. What temporary actions that you have seen taken in response to COVID do you hope may be made permanent because of their contribution to health equity?
Well, I'll relate this one, but I think some of the loosened regulations, as I mentioned, around telehealth, around who's able to provide certain types of services, I think that makes care more accessible, and so that to me is a good thing. Honest to God, I don't think I've seen very many interventions, and I'd be interested.
Yeah, I mean,
you have that are really moving in that direction. I think we're still in particular crisis mode. I do think that the issues, again, of the food insecurity, of the housing, I hope the crisis that we're in now doesn't people don't see, well, that was because of X, Y, and Z, but it shows you how porous the safety net is that we have, and how close to the edge many in our country are. So, a week's worth of unemployment really causes devastating effects. So again, it's not just the income inequality, but it's also the wealth gap and what people have in reserves to do. So honest to God, I don't think I have seen any policies yet that have moved us in that direction towards health equity. Even the one I gave you is a stretch, but I think hopefully that will cause us to think harder about what needs to be in place so that people aren't as vulnerable, when this comes back again.
Yeah, well, I'll just echo that a little bit. I think different states have done different things. The Commonwealth of Massachusetts has done, for example, has put in place efforts to try to help in context of homelessness, context of people who are incarcerated at this moment in time. I think the biggest lesson is how much of that was necessary because of how many glaring social structural needs there were that we realized very quickly were not only harming people's health who were vulnerable, but also harming everybody's health in the context of COVID. So the biggest lesson I think for us should be to take that and realize that we need to put these changes and make them and fix them structurally in the long term.
Yeah, we've done that here in Philly too, of housing homeless who've been COVID positive, but that's just a knee jerk. That's a knee jerk response for exactly the reasons that you said. To the extent that now we're going to really make sure that everybody in America has a home. I don't think we're there yet.
No, I don't think so either. But hopefully, COVID will teach us that once and for all. One can dream. Let me ask another COVID question from Erica. Insofar as COVID has shown us the disproportionate burden on African Americans and other groups as well, because of underlying morbidity, what do you think is a priority research agenda in a post-COVID world that highlights what policies we need to put in place to narrow those kind of health gaps, to prevent this kind of disproportionate morbidity burden that makes us differentially susceptible to something like this in future?
I am not sure that it's a research question. I mean, I'm not sure how much more research we need to understand that African American, Latinos, Native Americans, homeless suffer from health inequities. I think what we need is more intervention work and looking at policy solutions, maybe some, I would love to see a lot of rapid innovation in terms of how we prevent this, because we know. That's an interesting, it's an interesting question. I'm in the, sitting on the National Academy of Medicine, and we're looking at the next phase of the program of the culture of health. And what we're looking at or debating is, what is the science base that we need to address health inequities? And I think that's sort of my reaction here, is like, what else do we need to know from a science basis? Really.
No,
we're not going to get a magic pill to address that, but I would love to see more interventions and more things that drive us to solutions. Because as I said, I don't think they're at the interpersonal level. I think at the point of care there may be an opportunity for interventions, but I think we need bolder action. So I'd love to see some demonstration projects. I'd love to see, which again should be submitted to a rigorous evaluation. But that's where I think our efforts need to be.
I love the idea of the rapid innovation at this moment in time. I'm going to ask one last question, because I actually think it captures nicely the theme of your talk. Is from Erica, who says, resistance to change is in many ways our biggest obstacle to reducing health inequities. The groups that are affected are often the ones most disempowered to advocate for change. How do we overcome inertia to create sustainable policy change?
If you have the answer to that, one.
I think Erica's hoping you do.
I think we have to take this. I think we use this as an opportunity. What we're saying is, you can't waste a good crisis. So how is it that we can? How is it that I'm looking at? I'm imagining a bunch of youthful people here in the audience here saying that this is your time. I may be tired. I'm not hopeless. But I think you have energy, a renewed energy for dealing with this, for seeing this. This is your future. And so I would go forth with all the enthusiasm and ideas that you have, and don't let anybody tell you you can't. And talk to people and move together and get it done. I just say seize the moment. I
think that is a wonderful benediction. Thank you. I couldn't agree more. It is the time for public health. And Tony, well, I think neither you nor I would like to feel like we're completely done, but it is the next generation that's going to carry us forward. And I am always excited to see our students, and my charge always is go out there and create a healthier world for all of us.
There you go.
Thank you for what you are to do that. Thank you for what you're doing at this time in particular, and for everything you've taught us over decades and what you'll teach us over many more decades. I really enjoyed our conversation. I really enjoyed your talk. Thank you so very much.
Great. Thanks, Andrew. Bye, everybody.
Bye, everybody.